Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thank you for joining us for this webinar, which is going to provide hospice professionals information about the recently released final rule for fiscal year 2021. My name is Laura Barnett. I'm on the marketing team at Axxess. I'm glad to be with you today. Before we get started with the content of the webinar, I'd like to share a little bit about Axxess. We are a leading technology company serving organizations that provide healthcare in the home. We offer a complete suite of easy-to-use, innovative software solutions, empowering hospice, home health, and home care providers to grow their business while making lives better. A couple of housekeeping things. If you have a question, please submit that through the chat box. And if we have time at the end of the webinar, we'll get to those. If we happen to run out of time and we don't get to answer your question, we will follow up with you via email after today's webinar. Today, you're going to hear from my colleague and friend, hospice expert Zaundra Ellis. Zaundra was hospice employee number 1 at Axxess, and she has worked to build Axxess Hospice, which, as you know, was built by hospice experts for hospice professionals. She brings her 2 decades of hospice expertise, where she shares our solution with hospice organizations nationwide. Zaundra, I know you've got a lot to cover today, so please take it away.
Good morning, Laura, and thank you for that introduction. I am delighted to be here today and to share the changes for the hospice industry as we prepare for the fiscal year 2021. During today's presentation, we're going to talk about adjustment to the payment rates. We'll review the new cap amount, changes to the election statement content, and finally the election statement addendum. It's been much awaited. It's finally here, and I'm delighted to share the content with you. So the fiscal year 2021 payment rates in the proposed fiscal year wage index, we expected a 3% increase. We got a 2.4% increase, so a little less than we expected. And quite different from the rebase rates that we got last year that significantly increased our continuous home care, our inpatient respite care, and our general inpatient care. And you can see here the comparison between the 2020 payment rates and the 2021 payment rates. So it's important to recognize here that these rates are not adjusted to reflect a reduction in payment for that might be recognized if an agency is not participating in the hospice quality reporting program. So, you know, it's important that you get your hospice item set data transmitted to meet that threshold to avoid a 2% reduction in payment. Additionally, your CAPS data reporting, important to meet that threshold to avoid a 2% reduction there. So these are the base rates. So you'll need to add your CBSA rate to that, and keep in mind if you're not participating in the hospice quality reporting program, that you will need to reduce these payments by 4%. And while we're talking about hospice quality reporting, there was in the final rule this year, there were no changes to the hospice quality reporting program. However, there is a proposal on the table and kind of in the works to bridge the gap between the hospice item set and the CAPS reporting. So what hospice quality reporting is looking at is pulling claims data that would reflect quality of care while the patient is on service. So if you're not participating in the hospice quality reporting monthly calls, please take a moment to visit the hospice quality reporting website, get on those monthly calls so that you can be an active participant. They're doing a wonderful job of allowing providers to have active involvement in program development. So it's a great time to be involved and influence future quality reporting measures. I'll get off that little commercial now. The final rule did have some changes in CBSA designations. So the adjustments that they made were established in 2018, and they continue to follow us today. So if you are a rural, if you're designated as a rural county, there is a chance that you may now be designated as an urban county, and likewise, our urban counties may have been changed to a rural county. And as we know with payer mixes, that can significantly change the amount you're reimbursed. So it's important to understand that your designation may have changed. If you have a significant change in your wage index value and your reimbursement rate for this year, that is capped at a maximum of 5% for this year. Next year, you will see the full reduction in that payment. So as you think about that and the counties that you serve, you need to make sure that you go in and check your CBSA codes for each patient that you serve if you serve multiple counties before you bill on October 1st. Update those codes, make sure that you have them correct. If they have changed, if you don't update them when you submit your claims, those claims could be rejected. So make sure that you take the time to research and make those very important updates prior to submitting your claims on October 1st. We want to make sure that you get your hard-earned revenue. And keep in mind that 5% reduction when you are budgeting for next year, and then understand that if it's in excess of 5%, that you will see the full reduction in fiscal year 2022. The cap amount for fiscal year 2021 has increased the 2.4% that we see across the board. So $30,683.93. So I put the date of September 30th, 2025 here. So the current regulations around the hospice cap expire on September 30th, 2025. So we can expect in the next year or so to really see how the cap is calculated, and possibly a retooling of the hospice cap altogether between now and 2025. And we really need to be paying attention to policy around that. So currently, the Office of Investigator General is continuing to push for a 20% cap rate across the board. So their goal is to eliminate a dollar amount, but instead replace that with a 20% cap. So based on the hospice total revenue, the cap rate would be 20% of the total revenue for that hospice agency. So what the OIG reports is that about 16% of hospice agencies fall into what they fall into cap each year. So that means that 16% of hospice agencies are having to pay money back to CMS each year because they have collected money in excess of cap for each Medicare beneficiary that they have cared for throughout that fiscal year. In addition to, and the reasoning behind the 20% cap rate is the OIG firmly believes that nonprofit hospice agencies, which do not fall into that 16% of hospice agencies that have cap issues, are better served to provide hospice to Medicare beneficiaries. So it's a very interesting concept. The OIG is a very powerful organization, and while they do not legislate or regulate the hospice industry, they certainly influence CMS, and they do have a certain amount of influence on Capitol Hill, and those lawmakers also influence CMS. So it's a very interesting triangle. Public policy is important. National organizations like the National Hospice and Palliative Care Organization have a very active regulatory and policy, have a very active public policy committee, and it would be a good time to get involved. So whether it's state or national, it's a good time to get involved because 2025 will be here before we know it, and we can count on CAP as we know it to change significantly, and it's our responsibility to inform those changes. So now to the hospice election statement. This is a small part of the addendum that we have been looking for to change. So because the hospice addendum statement is introduced in the election statement, changes have been made to the election statement. So as a part of the final rule, CMS did provide a sample hospice election statement. And I know that many of you have hospice election statements that you use many times. There is a lot of information on those election statements. So whether it is the required CMS language, sometimes the organizations that we work for have included specific information, maybe policies that you have, internal policies that you have are included in some legal language that's included there. But I found it very interesting that the hospice election statement provided by CMS in the final rule really included these sections. So a very abbreviated hospice election statement. So the beneficiary name, which we always expect, and the election date, we expect those. Those were sections on the form, and you guys can find these on the CMS website. The right to choose the attending physician remains the same. We'll talk about the hospice philosophy and coverage of hospice care. That they give us specific guidance there, and the right to request patient notification of hospice non-covered items, services, and drugs. So this is the first time that we see language regarding or around that addendum statement. And then the beneficiary and family-centered care quality organization, otherwise known as the BFCC-QIO. So that is now required to be included on the hospice election statement. And we'll talk about what that is momentarily, but it's important that we notify our hospice beneficiaries or their legal representatives in the event that they're making that hospice election for the beneficiary of these things, and it has to be in writing on that election statement. So let's talk about in writing. So CMS, their intent is for hospice agencies to provide documents in writing. So we know that we live in a world of technology now, and a lot of things are delivered electronically, whether you have patient family portals or email, secure messaging. We have a lot of things in our personal lives that we get electronically now. So CMS does recognize that. The caveat is that that is acceptable. It is acceptable to provide things in writing electronically. However, if requested, it has to be, the document also has to be provided, a paper copy has to be provided as well. They don't give a time frame to provide that in writing. So make sure when you're meeting with your families that you have a clear understanding of whether electronic documents are okay with them, or if they prefer things in writing. Get that documented and make sure that you meet their needs and respect their rights as patients. Okay, the required language for the hospice philosophy and coverage is that hospice is palliative rather than curative, as it relates to the terminal illness and related illnesses. So we need to make sure that we're really infusing everything that we do at the time of admission with the language of terminal illness and related illnesses, because as we move through and we talk about this new addendum, what we're really going to be focusing on is terminal illness and related illnesses. So it's important that we start using those words often, that we're working with our team so that they understand terminal illness and related illnesses. They can use related conditions, but we need to start using those words, right? Because as we move through and we understand that our reimbursement hinges on these things, we want to make sure that we're using the right words, that our patients and their loved ones understand these words, and that it is really a philosophy that we're embracing as an organization. To shore that up, not really new, but CMS really is reinforcing that our election of benefits specifically states that the beneficiary is waiving all rights to have payment by Medicare for the terminal illness and related illnesses waived. So we really need to be taking our time, just like with the palliative care. We really need to be taking our time to explain this, waiving the rights to Medicare Part A benefits as it relates to our terminal illnesses and related illnesses. We need to be taking our time and explaining that in full to our patients or their legal representative at the time of admission. So if you have a team that goes out and does the admission, so maybe you have a social worker and a nurse, it's very appropriate to have both of them explain the philosophy and coverage of hospice benefits for Medicare beneficiaries and check for understanding, and then both should document the conversation and the fact that they checked for understanding. So it's a good standard of practice to, during the first week or so, to continue to go back and check for understanding here, and then periodically throughout the patient's time on hospice. I know of hospice agencies that will do this when they recertify the patient. I know one hospice agency that does it every time that they update the plan of care. So every 15 days they go in and they document these things. So this has always been a standard in hospice. CMS is really putting some teeth into it here with this addendum statement. And now is the time to put a process in place for the education of not only your team, but your patients and their legal representatives. So let's talk about the hospice election statement addendum. So this is a lot to take in, lots of words on this page. Keep in mind that we've got a little time to get this in place. The patient notification of hospice non-covered items, services, and drugs. So CMS uses this interchangeably with the hospice election statement addendum. So I would suggest that you use both of those terms. I would like to point out that this was introduced in last year's final rule. It was discussed, and then COVID-19 happened this year. Hospice and home care organizations lobbied CMS to delay implementation of the hospice election statement addendum until next year. We've just all had a lot going on, not a lot of time to spend on implementing a big change like this. And CMS response was, you've had enough time, we're going to do it. So here we are. And the intent of this is to really provide coverage transparency for Medicare beneficiaries and to protect their rights. So the rights of patients to really understand the hospice philosophy and what is covered and what is not covered under the hospice benefit. So the hospice election statement addendum, just like the hospice election statement, must include the beneficiary and family-centered care quality organization information. So now we see this in two places. So it's important to remember that it has to be in both places. And we'll talk a little bit more about the BFCC-QIO in a few minutes so that you can have a good understanding of which organization is yours and how to get in touch with them and provide the information that you need for your patients. So keep in mind that the hospice election statement addendum is a condition for payment. So very important that you get your process in place and that you have proof that you're doing it so that if you get audited, you're able to provide the documentation needed to retain your hard-earned money. So how does it work? So it is provided upon request. So when a patient is admitted, the patient or their legal representative can request it within 5 days of admission. So they can request it and the hospice agency has 5 days to produce it. So when they're admitted, the hospice agency has 5 days to produce it. So that gives the hospice agency the 5 days needed to complete their comprehensive assessment of the patient. So this would be an excellent time to identify whether the patient would like it electronically or in writing. Now, once the patient has been admitted and the 5 days have passed, they can request it at any time. So in that case, the hospice agency has 72 hours to produce the hospice election statement addendum. So it is up to the hospice agency to determine how they want to provide the information. CMS did provide a sample form for hospice agencies to use. So electronic medical record organizations have been working with the National Home Care Associations to get more information from CMS about the processes. So you can look for those coming in the future. So it is important now to develop your own processes. There are questions about updates to the hospice election statement addendum. So as you're caring for your patients, we know as hospice providers, medications, services, and supplies change frequently, very frequently. So when we're caring for our patients and we're changing, maybe we're adding a medication, or maybe we're changing a frequency, or maybe we're stopping pet therapy. All of those are updates that can affect the hospice election statement addendum. CMS has not provided clarification on how those are to be communicated to a patient or legal representative that has requested an election statement addendum. So if our patient at the time of admission says, I want a hospice election statement addendum, I want to know what is covered, what is related, what is covered, what is related to my terminal illness, and what is not. When that changes, we are required to provide that information. But if it changes, we don't know the mechanism of how we are supposed to notify, or if we are supposed to notify that beneficiary of those changes. So, we will continue to work with CMS to get clarification on that. As of now, a best practice would be anytime that you're updating the plan of care, that would be a good time to update your hospice election statement addendum. Have that ready to provide to your patient upon request. That would be the easiest way to keep track of that. So when you think about things that are related and unrelated, and how we're going to keep track of what's not covered, most of that will flow through your plan of care. So that would be the best time to capture that information and to make sure that you're communicating that with your patient and in a timely manner. So it's going to be up to your agency to develop that process. So I think this time next year, we will have a lot more guidance from CMS, and we will be able to streamline that operation and have some best practices as we learn and go through this process. CMS did address other requesters of the addendum. So let's talk about that. So our patient, their legal representative, of course, the Medicare administrative contractor can request the addendum, but also a non-hospice provider can request that addendum. So the addendum, again, is really speaking to the non-covered services, supplies, supplies and treatment. So a non-hospice provider might want to see that for treatment purposes, just to have in writing that hospice is not covering the treatment or service that they're providing. So in that case, CMS does acknowledge that that is a HIPAA compliant request, so that the hospice agency is allowed to provide that addendum to another healthcare provider and be HIPAA compliant. However, CMS does go on to say that the hospice must develop a process for providing that addendum statement and documenting the provision of the addendum to the other requester. So, when we think about that, we think about the OIG and their statement that it is a rare and unusual circumstance that there is a service, treatment, or supply that a hospice patient should need outside of, that should not be covered by the hospice Medicare benefit. So we can expect that non-hospice providers will begin to, that previously would bill Medicare Part A for service or treatment provided to a hospice patient, only to have that rejected, right? That claim rejected, and then come back to the hospice and say, hey, this was rejected because this patient was on hospice. Can you pay me? Can we work this out? We should expect them to begin to request these documents. So the hospice agency is really going to have a nice process for providing and documenting the provision of this addendum. So it's really going to tighten up that collaboration between hospice and non-hospice providers who are providing Medicare Part A services to hospice patients. So, you know, we've always been able to provide services through contract. You know, the hospice is always responsible for services and treatments that are related to the terminal diagnosis and those related conditions. But sometimes things get away from us. Maybe a patient or family member go outside of the benefit or go outside of the hospice and seek some treatment, and it gets away from us a little bit. But this is going to help in those cases where maybe that physician's office, you know, will call the hospice agency and say, hey, Miss Smith's daughter called and she's asking us to do this treatment. Can you send us an addendum that it's not covered? Well, now we have this addendum. We need to have a process in place. You know, it's not enough just to send the addendum over. We're going to have a process in place, be able to show that process, and also show the documentation that we sent that addendum over when requested. So just a little caveat there, and depending on your relationship with other Medicare Part A providers in your community, it could create quite a lot of work for your team. So something important to keep in mind there. So let's go ahead and talk about the difference between the advanced beneficiary notice, the ABN, and our new election statement. So we've had the ABN for quite some time. So the ABN, if an item is usually paid for by Medicare Part A, but it's not considered reasonable or necessary. So we might see an ABN, you know, if a patient is demanding continuous care, but upon assessment, they're, you know, routine home care. So, you know, that's a reason why you might use an advanced beneficiary notice. For the election statement, which is different, this is really about relatedness. So, you know, we've been tracking relatedness for quite some time, you know, having our physicians document that relatedness or not relatedness for drugs for quite some time. You know, it's a good standard of practice. So the election statement addendum, you know, requires hospice agencies to, you know, bring that across the board. So the ABN, you know, that is something that it's not considered reasonable or necessary. And the election statement addendum has more to do with your related items. So, and when you're thinking about relatedness, don't just think about your terminal diagnosis. Think about all of the related diagnoses that your patients might have. And, you know, when we think about our patients and related diagnoses, you know, those can get, what I find is some hospice agencies will have conversations about relatedness, and they're rather brief. So, you know, when you're talking about relatedness, make sure that you're not having that kind of keyhole conversation where you're just really looking through that keyhole and you're saying, okay, you know, this patient has Alzheimer's. So, you know, we need to, you know, cover medications related to their neurological deficits, right? So, you know, that keyhole view of the patient. Make sure that you open the door all of the way, right? So look at the entire patient. So you have a patient, you have an Alzheimer's patient, you know, and so those neurological meds, but, you know, what about anxiety medication? You know, what about, you know, they fell, you know, and they fractured their arm, You know, what about pain medications? What about treatment for that? You know, when you really start looking at your patient holistically and getting to the root cause of issues that they have, you know, whether it be pain, anxiety, any discomfort that they're having, and the root cause of that, many times you find that it really is related to that terminal diagnosis. So, you know, when CMS says terminal diagnosis and related conditions, they're sending that message down to the Medicare administrative contractors who, you know, when they're auditing your charts, they're opening the door and they're looking at the patient top to bottom. They're looking at the whole story and how each symptom, how each diagnosis flow together to the patient's diagnosis. So really what CMS is telling us here with this election statement addendum is don't look through the keyhole, open the door, look at the patient, and make sure that you're documenting things that are unrelated. So, and I think as you guys go through and really start looking at this, you're going to see that there are very few things that are unrelated, and that the OIG statement that is a rare exception that things are unrelated to the terminal diagnosis is probably true. Okay, let's move on to learn a little bit more about the beneficiary and family-centered care quality organizations. So these organizations have been in place for quite some time. They are actually led by the Centers for Medicare and Medicaid Services. So they are an extension of the Medicare and Medicaid Services. When you go to their website, it's got the Centers for Medicare and Medicaid Services logo on them. They have, they really do infuse quality at the community level for Medicare beneficiaries. And I think it's important to recognize when I was understanding more about the BFCC-QIO organizations, and there are only two, that they focus not only on the community and Medicare beneficiaries, but they also focus on the providers. So we do see post-acute providers there, not so much hospice, more you know, home care and community-based services, but they do have provider resources there. They do align with the CMS Meaningful Measures framework, which from the ground up is based on improving community care for Medicare beneficiaries. So whether that's institutional care, whether that's care in the home, they really want to save the Medicare Trust Fund by improving the quality of care that Medicare beneficiaries receive. So they do have immediate advocacy process. So this is where our new addendum comes in. And so the information that we're going to be including in on the election statement and on the election addendum is going to be the immediate advocacy information. So this is where our Medicare beneficiaries, if they don't agree with our assessment of what is not covered by the hospice benefit, they're going to contact the BFCC-QIO for your region, and the BFCC-QIO will act as an intermediary to appeal the decision that the hospice has made on behalf of the beneficiary. So that is one of the things that they do. I think the healthcare navigation services is more of their strong point. I think their immediate advocacy process is something that's going to come to the forefront, and I think it will be very interesting to see how it is handled with the influx of calls and emails that they get with Medicare beneficiaries once the election addendum is rolled out. So the quality care organizations, the care quality organizations, like I said, there are only two. They operate much like the MACs. So you can search BFCC-QIO on the internet. You'll go to the website. There are two of them. You can do a search by state, and it will tell you which one services your region, just like your Medicare administrative contractor. I encourage you to visit those websites, get to know them, go ahead and make contact with them. You're going to be working with them, get to understand their processes early. There's no reason why we can't have a collaborative relationship with them. And I think that reaching out early will be beneficial for not only the hospice organization, but more importantly for the Medicare beneficiary who might contact them if they feel the need to have someone advocate on their behalf. Okay, so let's talk about action items. So in the final rule, Medicare has a lot of language about hospice agencies designing their own processes. So CMS has given us a lot of work to do, but has not provided a lot of guidance or framework of what they want to see. And so those of us who have worked in the hospice industry for quite some time understand, you know, that can be a great opportunity for hospice agencies that are proactive. So as we think about the work that has to be done, we need to update our election statements. We need to develop the addendum statement. We need to make sure that we have a process in place to educate our team, get things done. So every agency is going to have a different way to do that. So in order to get it done, you have to design your process. And as leaders of your organization, you know your team. So whether that is a top-down design process or whether that is a collaborative effort. It's August. We have to have this done and in place by the 1st of October. So educating your team, getting their buy-in is the first step. So they need to understand the new requirements and how it applies to them, how it applies to your current patients and your new patients. Then you will need to develop a process to educate your current patients, right? They will have the right to request an addendum. So you're going to need to educate them. Is your organization going to have them sign an updated election statement with the quality advocacy organization information on there and the election addendum statement organization on information on there? So we've got a couple of things going on. So We need to take care of our current patients. So we need to make sure that they have the information about our quality organization. We need to make sure that they have information about their rights to request the addendum to the election of benefits. So do we update that election statement? Do we provide something in writing and add that to their medical record? And then we need to put something in place for our new patients. So we need to definitely add the documents to the admission packet, right? But we also need to have a place to document that education. So how do we document that we educated the patient or their legal representative at the time of admission on their rights to contact the quality organizations and their right to request the election statement addendum? So we've got multiple things going on here. And for our current and new patients, what is the process going to be for requesting a modified election statement addendum? You know, so, or is your agency going to automatically provide them with a modified statement once they've requested election addendum? So lots of moving parts here. And, you know, I would argue that, you know, it's a situation that it's going to take multiple people to make the best decision for your team. You know, at Axxess, we say the best idea wins. So, you know, you can get a group of people in the room, maybe your QAPI team, maybe your IDG team, and really talk about the best process for your team so that you can come up with the best idea for your current patients, for your future patients, and for your team, so that you can infuse this knowledge throughout your organization and be ready to go on October 1st. And of course, we need to design a process for our vendors. So many of your vendors are also Medicare Part A providers. Maybe they're Medicare Part D providers. So let's talk about our pharmacies. So Medicare Part D and the hospice benefit, that has been on the radar for a long time. My hospice friends that were working in the hospice industry in 2014 may remember when CMS put into place, you know, the fax that we had to send to Medicare Part D plan, notifying the plan that their member had come on hospice and what a mess it caused for about a week. We need to get ahead of this because I think we can look to a lot of pharmacies and expect them to be requesting these addendum statements. So these Part D plans, they're going to be requesting these. So let's think about, you know, what we can do to kind of get ahead of that. Get in touch with our pharmacies, our pharmacy benefit managers, make sure that we have, you know, a process in place to communicate with them. Don't wait till it happens. Let's make sure that we're ahead of the game and that we're in control of the process from the beginning. And then as we move through the process after October 1st, and things start moving along, make sure and include all of this in your quality assurance and performance improvement program. We know that this all hinges, that payment hinges on this running smoothly. So we don't want your payment to get hung up. And, you know, you might be Johnny on the spot at the beginning, but as you kind of go along, it's easy to miss things. You know, but if you have extra eyes looking on it, it's part of your QAPI monthly reporting or quarterly reporting. I hope you're having monthly meetings, but if it's quarterly, meetings. That's great. You know, let's look at your successes there, you know, and if you're not having successes there, develop a performance improvement project. Let's have a PIP project and see what we can do better. And let's go back and look at our process. You know, what can we do different? We did, you know, we provided education, you know, we considered our current patients, our new patients, and our vendors. What else can we do? How can we do that different? You know, we want to make sure that we're compliant, that we're providing exceptional hospice care, but let's really focus on making it better and being compliant. So that's what I have for today. Do we have any questions, Laura?
Not that I see, no. So I think we're in good shape. We can get wrapped up. Zaundra, thank you so much for joining us today, and thank all of you for carving time out of your day. We know that you're busy, so we appreciate you spending about an hour with us today. And as we're delivering on our mission to empower healthcare organizations and professionals with the world's best technology solutions, we greatly appreciate your time and your attention. And if there were questions that did happen to pop in and I don't see them, we will follow up with you via email, but none that I see. So I think we're in pretty good shape. So everybody have a wonderful rest of your day. And feel free to visit axxess.com/hospice if you have any other questions about our hospice solution or our complete suite of solutions. You can visit axxess.com to learn more. Thanks so much. Have a wonderful day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.